I would like to present our review on the role of locoregional therapies in the management of patients with hepatocellular carcinoma. Hepatocellular carcinoma, HCC, is the sixth most common cancer and third cause of cancer-related deaths worldwide in 2020. Liver resection and transplantation remain the cornerstone for patients with early-stage disease and represent the only option for potential cure in HCC. However, the reported resectability rate is low, with less than 10% of patients satisfying preoperative criteria for resection, with post-hepatectomy recurrence rates up to 50% at 2 years and 70% at 5 years. Further, few patients meet the accepted transplant criteria, and the chronic shortage of donor organs makes liver transplantation an unrealistic option for many patients. Hence, locoregional therapies have been developed, and globally it is estimated that up to 60% of HCC patients might receive locoregional therapies in their lifetime. International societies, including the American Association for the Study of the Liver, AASLD, the European Association for the Study of the Liver, EASL, and the Asia-Pacific Association for the Study of the Liver, APASL, recognize that locoregional therapies are integral to the management of HCC patients who have unresectable disease or those who are deemed unfit for surgery. The Barcelona Clinic Liver Cancer (BCLC) treatment algorithm has been widely adopted to help guide therapeutic strategies, as shown in this figure here. This review discusses the role of locoregional therapies in HCC management and the emergence of immune and systemic treatments. Locoregional therapies are minimally invasive, image-guided, liver tumour-directed procedures integral to the management of HCC. This diagram summarizes the different modalities of locoregional therapy in the management of HCC. Image-guided ablative therapy can be thermal, including radiofrequency, microwave, or cryoablation, and non-thermal, which includes chemical ablation such as percutaneous ethanol injection and irreversible electroporation. The three societies, AASLD, EASL, and APASL, all recommend RFA as the first-line therapy for solitary tumours less than 2 centimetres. For single tumours between 3 and 4 centimetres, or 2 to 3 tumours or less than 3 centimetres, both the AASLD and EASL recommend RFA as an alternative to surgery, whereas the APASL recommends RFA as an alternative to surgery for patients with less than or equal to 3 nodules, all of which less than or equal to 3 centimetres, with child A or B cirrhosis. So, what is the evidence? When comparing liver resection with RFA, there is level 1 evidence to suggest that there is no difference in all-cause mortality for early-stage HCC, and no difference in overall or disease-free survival for recurrent HCC. When comparing RFA with percutaneous ethanol injection, there is level 1 evidence to support that RFA is superior in objective response rates and overall survival. When comparing RFA with microwave ablation, there is evidence to suggest that there is no difference in local tumour progression, treatment-related morbidity, overall and disease-free survival between the two ablative therapies. However, there is a trend towards greater efficacy but higher complication rate in HCC larger than 3 centimetres treated with microwave ablation. Transcatheter intraarterial therapies are centered on the principle of parenchymal arterialization, sinusoidal capillarization, and the development of unpaired arteries that occur during HCC carcinogenesis, whereas normal hepatocytes receive dual blood supply predominantly from the portal vein. The objective of transarterial embolization is to selectively deprive arterial inflow to the tumour, which causes ischemia-induced cellular membrane disruption, resulting in ischemic necrosis. Although the arterial supply of the treated segment is compromised after embolization, a patent portal vein compensates hepatocyte perfusion, thereby decreasing injury to normal parenchyma. The AASLD, EASL, and APASL guidelines all recommend transarterial chemoembolization, or TACE, for patients with intermediate stage HCC, or BCLC stage B, defined as multinodular disease, performance status 0, child A or B, without portal vein invasion or extrahepatic disease. TACE is the most common locoregional therapy used for downstaging or bridging treatment to meet or stay within transplant criteria. TACE is preferred over ablative therapies in some centres due to the small but real risk of tumour seeding associated with ablative therapies. The indications and contraindications of transarterial radioembolization, or TARE, are similar to those of TACE. Again, what is the evidence? There is level 1 evidence to support that patient with intermediate stage HCC had improved 2-year survival when treated with TACE compared to best supportive care alone. When comparing conventional TACE with drug-eluting bead chemoembolization, or DEB-TACE, there is no difference in overall survival. However, the Precision 5 study showed that with DEB-TACE, there is increased tumour response and less liver toxicity and less doxorubicin-related adverse events. With regards to radioembolization, there is level 1 evidence to suggest that radioembolization is a safe alternative to TACE in the management of intermediate stage HCC. Whereas in the management of advanced or BCLC stage C HCC, current evidence shows no survival benefit with radioembolization compared to best supportive care alone. However, in these trials, standard dosimetry was used rather than personalized higher dose dosimetry. Stereotactic body radiotherapy, or SBRT, is a form of external beam radiotherapy that accurately delivers high-dose radiation in one or few treatment fractions to the target tumour, while limiting the radiation dose to the adjacent non-target liver. At present, only the AASLD guidelines accept SBRT as a treatment option for early tumours. Neither EASL nor APASL recommend SBRT as a treatment option. There is some evidence to suggest that for early HCC, SBRT achieves similar local disease control, but overall survival is better with RFA. Whereas for intermediate HCC, both TACE and SBRT have comparable local control and survival. For advanced HCC, the combination of TACE and SBRT was shown to have improved progression-free survival, overall response rate, time to progression, and overall survival compared to sorafenib alone. As RFA is the only locoregional therapy that can achieve complete response and comparable survival rates as surgical resection in selected patients, much research has been dedicated to the utility of combination therapies with a goal to improve observed response rate and survival rates in patients with intermediate or advanced HCC. Several studies have investigated the combination of RFA and TACE. The hypothesis for improved efficacy in cases where RFA is performed before TACE is that the increased blood flow and vascular permeability observed in areas of sublethal heating at the peripheries of the ablation zone would facilitate delivery of the chemotherapeutic agent at relatively higher concentrations. In cases where TACE is performed before RFA, the heat sink effect is decreased by limiting hepatic arterial flow induced by TACE, thereby yielding a more complete central necrosis by RFA. Several studies have demonstrated that combination therapy of RFA and TACE is superior to monotherapy of either technique alone in terms of progression-free, recurrence-free, and overall survival. For years, sorafenib was the only systemic agent available for the treatment of unresectable HCC. The emergence of new immunotherapy and systemic therapy agents has changed the landscape of HCC management. The rationale for combining locoregional therapy with immunotherapy is that locoregional therapies have an immune modulation effect on the tumour microenvironment, transforming the inherent immunosuppressive nature of the liver microenvironment into an immunosupportive niche in which checkpoint inhibitor therapy might be more effective. Several clinical trials investigating the efficacy of combining locoregional therapy and systemic therapies have so far been disappointing, with studies either being terminated early due to futility or showing no survival benefit with combination therapy. Ongoing trials investigating the combination of locoregional therapies plus immune therapies and systemic therapies are summarized in this table here. This review also discusses the assessment of treatment response after locoregional therapy. Treatment response is usually assessed using computer tomography, CT, or magnetic resonance imaging, MRI. The aim is to recognize residual or recurrent tumour and to identify any complications of therapy, with the objective to determine prognosis and inform future management. There are many treatment response criteria, including World Health Organization, WHO, response evaluation criteria in solid tumours, RECIST 1.0 and 1.1, modified RECIST, mRECIST, EASL, and liver imaging reporting and data systems treatment response. This table summarizes the different response criteria. It is important to acknowledge that mRECIST and LRTR are the most commonly used criteria in the assessment of treatment response in the management of HCC, with LRTR being consistent with and fully integrated into the AASLD clinical practice guidelines. In conclusion, HCC is the sixth most common cancer and the third cause of cancer-related deaths worldwide. Overall survival has improved in recent years, but prognosis is still poor for advanced disease. Surgical resection and liver transplantation remain the cornerstone for cure in early-stage disease. There is an expanding role of locoregional therapy in the management of HCC. Locoregional therapies can be performed with curative, downstaging, bridging, debulking, or palliative intent. Ablative therapies have become the first-line treatment for non-surgical patients with very early HCC achieving curative outcomes. Transcatheter techniques offer major benefit for patients with intermediate HCC. Although patients with advanced HCC are currently limited to systemic therapy, the combination of locoregional and immune therapies shows promise in HCC management.